You're welcome to my channel. Today I'll be talking about cervical cancer treatment. If you haven't listened to all other presentations on cervical cancer, please kindly do, because we cannot just start with treatment. We must have addressed signs and symptoms, the risk factors, the pap test, human papilloma virus testing, cervical cancer, pap test and pregnancy, how to make diagnosis of cervical cancer, the staging of cervical cancer, all already published here. Now is all about treatment. The treatment will take multidisciplinary approach. Oncologists, gynecologists, family physicians, psychiatrists, nurses, pharmacists, dietitian, social worker, family members or substitute decision maker will all be involved. Now, psychotherapy or support group is necessary, particularly if the cancer is of the advanced stage. Social workers might be involved if there is need to handle some social issues. Family counseling is necessary, particularly when the stage is high up, like stage 4A or 4B, when the treatment will be intensive, or it's going to be palliative with the end of life. Child support services may be required. For example, a woman diagnosed with cervical cancer and pregnancy, and she has decided to take care of the pregnancy right now. No termination to keep the pregnancy, prevent treatment, and then she delivers after and dies, and the baby is right here with us. Now, child support services will be required to help out in that way. Since the treatment is not just one way for everybody, it is individualized, right? So we must check the pap test result, the biopsy, the cytology result, the stage of the cancer to make up our mind on the duration of the treatment. And we must determine the survival possibility, because it doesn't worry the stress of the treatment, the cause of the treatment, the side effects of the treatment, and the person is already the type that will not live for many years to come, then doesn't worry. And another issue here is, imagine someone with another diagnosis entirely, like lung cancer, having few months to live, and then on top of that is cervical carcinoma that is stage 2 that you can still salvage to some point, or stage 1 that will not warrant so much to be done. But then there's another concomitant situation on ground, pre-existing condition on ground that will not let her live long. So we'll put all this into consideration. The benefit to the mother and the child, the choice of the woman will determine what we do if it's a suitable pregnancy. And of course, everything must come with informed consent. We have to address family concerns like relationship, like pregnancy. If she's currently pregnant, are you going to keep this pregnancy, or you want us to have this treatment right now, particularly if it is invasive, okay? Future childbearing capability and interest. We'll put all these things into consideration before making the decision on which direction to go. Colonization. If the cancer is limited to the cervix, meaning cervical dysplasia, a cone-shaped piece of abnormal tissue with some normal tissue will be removed. Another word is biopsy, right? You can use scalpel or laser knife, and we are going to use the sample taken for histopathological examination. So we'll send that to the pathologist. LEEP means loop electrosurgical excision procedure, useful for microinvasive cervical cancer. Here, a wire loop could be used to remove the abnormal cells found. Loop electrosurgical excision procedure will remove abnormal cervical cells most of the time for further studies. However, that is not achieved all the time in everybody. So if for the first time that is not achieved, then you may have a repeat of the loop electrosurgical excision procedure, or you simply write a referral note to gynecologist or oncologist for further investigations and treatment. Hysterectomy. Hysterectomy could be simple, meaning the uterus and the cervix will be removed. So it might be subtotal. Subtotal hysterectomy means the uterus is removed while the cervix is in place. Okay, it might be total hysterectomy where the uterus with the cervix is removed. Total hysterectomy but with preserved fallopian tubes and ovary most of the time, and might be total hysterectomy with bilateral cervical-oophorectomy, meaning the fallopian tube and the ovaries are removed. Hysterectomy might be radical, where the uterus, the cervix, the upper vagina, surrounding tissue, and lymph nodes are all removed. Trachelectomy. Trachelectomy is helpful if fertility is still desired, either because the patient is still young or just because that is what the woman chooses to have. Okay? In that case, we then remove only the cervix with the tumor, and the uterus will still be left intact. Fallopian tubes will be intact, the ovaries will be intact. Radical trachelectomy will involve removing the cervix with lymph node dissection. Exenteration is not usually done anymore. In that case, if after radiotherapy the cancer reoccurs, then the surgeon will remove the pelvic structures, all of them like the rectum, the bladder, the lower colon, the uterus, vagina, like I said, not usually done any longer. Radiotherapy and chemotherapy. Yeah, we have to discuss fully the side effects of both modalities, meaning the side effects of radiotherapy and chemotherapy. Full agreement must be reached before the onset of the sessions. During the time the woman will be on radiotherapy, there should be no relationship. You can see what I put there, right? Now, radiation. Radiation will be good if we have the external beam or the internal radiation or brachytherapy using implants. It will be better to have both external and internal radiation combined. And it is best to combine chemo with external and internal radiation. Radiotherapy alone could be the choice of treatment if the woman cannot have chemotherapy and she's not good at the same time for surgery. Let me explain. You will limit the treatment to radiotherapy alone. If the woman cannot take chemotherapy and at the same time she cannot undergo surgery. Brachytherapy. This is the local application of radiation to the cervix or the vagina. It is used for locally advanced cancer and involves higher dose of radiation. One advantage here is that it's going to spare the surrounding normal tissue and could be given through pulse dose rate, interstitial, or intracavity. Now, chemotherapy. This will be given intravenously to protect the kidney. Intravenous chemotherapy is better. Chemoradiation, from those two words, meaning combination of both. Here, cisplatin will be given once weekly, or cisplatin and 5-fluorouracil every 4 weeks. Both are good sensitizers for radiation. Remember, carboplatin is also a good radiosensitizer. Then, you can have external radiation therapy at the same time. There will be no chemoradiation, meaning chemotherapy with radiation at the same time, if there's acute pelvic inflammatory disease, chronic pelvic inflammatory disease, dual malignancy coexisting, meaning another cancer existing along with cervical cancer. If pelvic anatomy is abnormal, that it will be unsuitable for radiotherapy, then no chemoradiation. And of course, topmost will be that patient won't want to comply. Then we don't need to force anyone. Chemotherapy could be better if it is combined. So combined chemotherapy can be cisplatin and ifosfamide, or cisplatin and paclitaxel, or cisplatin and gemcitabine, or cisplatin and topotecan. We can also choose from cisplatin, carboplatin, paclitaxel, epirubicin. They choose from mitomycin, ifosfamide, docetaxel, or doxorubicin. Can also choose from irinotecan, topotecan, gemcitabine, 5-fluorouracil, vinorelbine. Though chemoradiation is better, if you have just limited resources and you are dealing with an advanced local cervical cancer, then we can have neoadjuvant chemotherapy before surgery. Okay? And that will be suitable enough. Targeted therapy. Targeted therapy will be useful in advanced stages. Here, specific cancer genes will be targeted. Bevacizumab, that is Avastin, is useful for this purpose. It is a monoclonal antibody that targets the vascular endothelial growth factor. Immunotherapy. Biologic therapy or immunotherapy can make use of pembrolizumab to boost the immunity to fight the cancer after chemotherapy. Remission. Remission is defined that there are decrease in signs and symptoms, or there is the disappearance of signs and symptoms of the cancer. That's the good news, right? If you are told you are in remission, great. It might be partial remission, meaning there is some, but not all signs and symptoms of the cancer would have disappeared. So, it is simply put that partial remission means there is appreciable decrease in signs and symptoms, while remission means it is not appearing or very, very minimal in signs and symptoms. Recurrency. The cancer can return after the initial treatment, and the recurrency could be local, meaning occurring at the same place where it was found initially, or regional recurrency, meaning it's occurring nearby, or distant recurrency is occurring in another place entirely. You will embark on palliative only if we are dealing with advanced distant metastases already. Now, prognosis. Prognosis will depend on the following: the stage of the cancer, whether we're dealing with squamous cells or adenocarcinoma, the treatment already given, and whether the treatment is successful leading to remission or not, the onset of the treatment, because the earlier we start, the better for us, The remission reached or recurrency right now, either we are dealing with other comorbidity or morbidities, and the immune status. Immunocompromised, of course, we have bad prognosis. Immunocompetent with good treatment and treatment starting early, and of course, early stage of the cancer, all will give us good prognosis. Follow-up. We'll embark on follow-up for sure, but the treatment modality adopted and the general health status of the woman will determine the frequency. For example, this is first trimester, and it is not invasive. Then let the woman continue normal antenatal clinics, okay? But if this is a woman in second or third trimester, and we are going to delay the treatment of the cancer till after delivery, then we have to determine the frequency of follow-up based on the stage of the cancer, the clinical signs and symptoms. If this patient is young and she's not pregnant, then we can treat now and follow up after. If this patient is older or postmenopausal, we can treat now and follow up after. During the follow-up time, we can go over the history again. How are you feeling today? So we ask after signs and symptoms again, whether it is getting worse or not, depending on where we are. Is this a pregnant woman, non-invasive, do nothing, or pregnant woman, second trimester or third trimester with invasive cancer, do nothing? We'll know the history to us. Of course, how is the pregnancy doing? And how are you doing as per signs and symptoms of the cancer? Is it getting worse or not? Of course, appropriate thorough physical examination and pap test could be done depending on when last she had the pap test done. In conclusion, in all, the stage of the cancer will determine the treatment modality or modalities that will be suggested. The best thing to do is to follow your doctor's pieces of advice on pap testing, human papillomavirus DNA testing, and the modality already chosen. With that, I've come to the end of this presentation as per cervical cancer treatment. Remember to share this, and remember to subscribe to my channel, and remember to check this very channel for cervical cancer signs and symptoms, risk factors, diagnosis of cervical cancer, pap test or pap smear, pregnancy with pap test, staging of cervical cancer. And remember to subscribe. I appreciate it.